Hello everyone, welcome to tonight's webinar held by Allied Health Professions Australia and CSIRO Sparked program, the benefits of consistent terminology data standards for clinical practice. I'm Jackie O'Connor, the AHPA's Digital Health Program Manager, and be facilitating tonight's webinar. I'd like to begin by acknowledging the traditional custodians of country throughout Australia and the continuing connection to land, sea and community. We pay our respects to them and their cultures and to elders both past, present and emerging. We have people with us from all around the country here tonight, and from many different professions across the diverse scope of practice that is allied health, which is great because that's what we're aiming for, because this is really a topic that applies to us all equally, in that it's essential basically for all of us. We have a range of presenters lined up for you tonight to help you understand why the standards work that Sparked are conducting is the essential enabler to practicing, communicating and reporting the way that we all desire. Now we will have a Q&A session at the end only. We'll run through the presentations first and save the questions till the end. So if you could please use the Q&A function, which should be the second from the left button at the top of your page. If you'd like to put your Q&A questions in there, and then save the chat for other general bits and pieces, please. We'll focus in on the Q&A. We're still sorting out in the background, but we're hoping you might be able to sort of give that a thumbs up if we're thinking the same thing as a question that someone else has asked. Please give it a bit of thumbs up so we know to prioritise that if we have too many for the time we've got. And also some of our presenters might be able to easily answer some of those questions in writing during the session, so just keep an eye on that. I have popped into the chat also a link to the AHPA Digital Health Hub, where we're slowly but surely starting to build out all our digital health information. And we will be recording tonight's meeting and putting that up there. So you'll be able to access it through the Digital Health Hub, along with a whole lot of other resources in the future. All right, I'll just kick off tonight's webinar with letting you know that I guess setting the scene in a way that really the reason we're all here is because at the moment clinical information, or data as we'll refer to it a lot tonight, is contained in silos within various healthcare provider organisations. So what that results in really is the consumer being responsible for moving much of their health information around within the system and between providers, and creates many challenges really, from it being too much pressure on the consumer to be responsible for this data sharing role, to the data being shared being inconsistent and unavailable for collated analysis and use at research and policy level. So we know that collectively the government, the software industry and other key stakeholders like CSIRO and the agency are working on building an interoperable digital ecosystem. So an interoperable system really means we're aiming for the digital products you use as a healthcare professional, like your clinical information system, to record the health information and data you generate when providing care in a way that it can be shared with everyone else's software systems, irrelevant of what they are. So when we have that interoperable system, you'll be able to receive and share consumer health information in near real time to solve so many of the problems we see today in practice, like spending ages chasing the information you need to inform optimal care. So what this slide's trying to show is that once we have information flowing in this way all around the system, as opposed to only in and out via the consumer, then there is the potential to extract data at a national and global level to fill information gaps like workforce statistics, research on the value of care that we provide to inform policy planning and reform, and clinical level research that really at the moment we can't dream of producing to that extent. So when you think about those challenges it can solve, it's critical for the allied health sector to be involved in this, because for our sector, this kind of data is really absent compared to a number of other health professional groups, as well as, you know, other industries out there in the country. So in the absence of this big data being available now, but in a landscape where we are already shifting to value-based healthcare funding models and mandatory sharing of Medicare funded care plans and things like that, we really need this information and to be a part of it. So at AHPA, we're working with our member associations and the Australian Digital Health Agency on behalf of the sector to ensure that allied health information is included in software systems like My Health Record and Provider Connect Australia. But really, for you to be able to share information within an interoperable system in an efficient and high quality manner with any system, whether it be run by the agency or a software provider that you choose, and to do it in a way that's sustainable for your business and gains the respect of your colleagues, the software systems all have to be interoperable with one another, irrelevant of the system you want to use. So the key enabler to interoperability and sharing of high quality information is the ability for all the software systems to speak the same language. Now, this applies from hospitals to sole traders, from physios to psychologists to music therapists and orthotists, no matter what software system you're using. So the problem is, at the moment, we don't all speak or record information consistently with the same terms and language. So even with, we don't do that even within our own professional disciplines, let alone across the allied healthcare sector. So we need to standardise the way we talk and record information so that the software systems can share it. So as you can imagine, that's a pretty big task to get that consistent language across the sector and make sure that all that information we need to receive and share is captured in a system. But it is an essential one to get this interoperable world that we're dreaming of. So despite this task being seemingly huge, Sparked have begun and are finding a way. So I'll hand over to Tor from Spark now to explain more of the benefits you'll get from this work at a clinical level and how they're working on providing the opportunity for this interoperable world. Thank you, Tor. I'll stop sharing.
Thanks, Jackie. I'm just going to see if I can share my slides and hopefully you can all hear me okay. So for those that don't know me, my name is Tor Bendel and I'm a project engagement lead with the Sparked program. And also online with me tonight is Kylie Loy, who is the clinical design lead responsible for developing the Australian core clinical data for interoperability, which we'll discuss in a little bit later. So what I'm here tonight to talk to you about is to give you a bit of an overview of the Sparked program and the work that we're doing in that space. So for those that don't already know, Sparked is a nationally funded fire accelerator that's led by CSIRO's eHealth Research Centre in partnership with the Department of Health and Aged Care, the Australian Digital Health Agency and HL7 Australia as our standards body. It's a community-focused, consensus-based bottoms-up approach to standards development, and to enable that bottoms-up approach, one of the core components of the Sparked Fire Accelerator is the community, which is made up of our government, technology vendors, healthcare providers, peak bodies, practitioners, and domain experts. We're really trying to span the whole of healthcare ecosystem to incorporate as many perspectives and inputs into the development of these standards for health information exchange as widely as possible. So it's a government initiated and funded program. We're working collaboratively with the international fire community and other fire initiatives out there to create open standards using high priority use cases. So trying to develop the creation and the use of the national fire standards. So I mentioned that Sparked is a fire accelerator, and it's the first one outside of the US. But what is a fire accelerator for those that aren't familiar? FIRE stands for the Fast Healthcare Interoperability Resources. So these are an open set of rules and specifications that enable the secure exchange of electronic health data using modern web technology. It's not locked down to any one system or application or implementation even. Rather, it can be picked up and used across many different systems in many different environments. So a fire accelerator is a program of work that is dedicated to speeding up the process to develop and adopt these specifications to improve the exchange of that healthcare information. So this Sparked program, it's not a single app or system, but the community that are focused around creating these standards and looking to adopt and implement them into new and existing systems, importantly. So Jackie's already sort of touched on this quite eloquently, but why is this important? Because having an agreed way of defining and exchanging health data in systems means that we can enable that consistent and secure health information sharing across Australia, not just in a single jurisdiction or a single clinical area, but across different borders and different environments. So what does it mean in terms of actual outputs or artifacts that you can access when we talk about the Sparked Fire Accelerator? So there's 3 core areas and 2 sort of enabling or supporting areas that make up the program that we're working on. So the first core area is AUCDI. It's the Australian Core Clinical Data for Interoperability. So these are the clinician-focused data requirements that define the consistent meaning and context of the clinical data that's captured in our electronic systems. It's a foundational data model that can be applied to multiple use cases in an Australian healthcare context. Secondly, the clinical terminology and value sets is another core area of the Sparked Fire Accelerator. So these specify what language and terms should be used for data entry and for sharing. So for example, the SNOMED clinical terminology or LOINC are terminologies that may be used in different areas of the AUCDI to help define the actual clinical concepts. So defining the terminology, sorry, I've skipped ahead. Let me go back 1 second. Defining the terminology value sets means that we're taking these complex clinical concepts and ensuring that they are represented in a codified way. So that means they're modeled properly and have the appropriate relationships and mappings in the clinical ontology models. So when we talk about a specific procedure, diagnosis, or test, the relationships and properties associated with those concepts are inherently understood and able to be exchanged with meaning in a structured way. So it's an enabler to quality data capture at the point of care and then being able to reuse that data many times in many different contexts. So when we have consistent agreed ways of sharing this data to ensure systems then know how to exchange that information and use that information, this is where the FIRE resources come in, the FIRE specifications come into play. So through the development of the FIRE implementation guides or FIRE AGs, their technical representation of the clinical information models can be sent across the wire between systems. So they specify how the information should be structured, accessed, and shared to support that consistent way of exchanging information between systems. So through Sparked, we've now published the first release of the Australian Core Data for Interoperability, Release 1, as well as the AUE requesting core data for interoperability. We're now working on the next release of AUCDI. We're aiming for end of June, which will be comprised of requirements that are informed by AU patient summary use case and the chronic condition management use case. So in January 2025 as well, we also published the first release of the AU Core FIRE Implementation Guide. So the specification, the technical specification of how to exchange that clinical data. And then we also have a draft version or a preview version of the AUE requesting FIRE IG or technical specification. So the two other areas of Sparked that I'm not going to go into a lot of detail over are the testing and piloting of these standards, making sure that they're fit for purpose and have been thoroughly tested as we build them out, that they make sense, that they're scalable. And then the other aspect that we are also looking at is identifying the different reference implementations for the community to use as a guide when they begin building out their fire-enabled products or systems. So why are we putting so much effort into trying to build out these standards? So why have an agreed national data standard for interoperability and technical exchange? So as many of you will know, and as Jackie's already touched on again, data is often fragmented and siloed in various systems, which don't talk to one another, leading to the duplicate documentation and re-entry of information over and over again. And I think most of us can agree that what we want is to be able to enter data once at the point of care and use it multiple times for various purposes. So having agreed data standards will ultimately enhance consumer experience, streamline clinical workflows, and enable data-driven decision-making at a population level. So it's a contributing asset to a more efficient and effective healthcare system. Breaking it down a bit more, how does better sharing of standardized information help the patient? Well, it reduces the need for the patient to tell their story over and over again. It doesn't rely on the patient to keep track of all the different pieces of paper, results, referrals, images. They can have it in applications, or they can have it on their phone, or however the various smart people can solve this problem, but they can basically take the information electronically and displayed in many different ways. So it allows the automation of mundane processes, for example, reminders, follow-ups, filling out of forms in advance, etc. It helps to improve safety and quality through a more coordinated care with better information access, and it supports rural and remote communities that can move between health settings and areas. And that's true of, I think, many people that move between the different environments, different places as they travel and things like that as well. So how does it help a healthcare provider or a clinician? So it enables streamlined workflows, reducing duplicate documentation and re-entry of information. And it means that you can have the information available at your fingertips when you need it. So in theory, this also enables a system that could be tailored to a specific workflow or environment, but still be able to be shared with other systems. So for example, what you see on screen can be meaningful to you and your particular clinical discipline, but how it's stored and shared behind the scenes aligns with the agreed standard. That means it can then be easily exchanged with other healthcare systems. It also means that other fun things, like supporting the automation of other administrative processes, enabling innovation to develop clinical decision support tools, modern AI tools and technologies, and streamline workflows, etc., like that can all be built out leveraging those same standards. So, for example, smart on fire tools allow for common forms to be pre-populated, resulting in better use of time and less errors. From a population level across the healthcare system, recording of data once and reusing for multiple purposes means that we can have more consistent processes for how we submit data to national registries, how we share data with research programs, meet minimum reporting requirements. It means that we can have a better picture and understanding across the whole of health system regarding service planning, epidemiological surveillance, health policy planning, risk stratification, measurement of outcomes, reporting of clinical indicators, and all things like that, that help us to build a learning healthcare system. So on a single page, I think this shows how at the different levels, the same data might be used by different aspects of the healthcare system, different levels of the healthcare system, to basically enable that system. So really what we're looking to do is to find the balance to ensure that we build a strong foundation to develop standards that are practical and support what exists now with little extra effort to support a model that is clinically useful but not overwhelming to implement from a technical aspect. So it's capable of supporting future technologies and innovation, but able to be used and picked up now. So that's a very quick overview, and I think on that note, I'll pause and hand back to you, Jackie, to introduce the next speaker.
Thank you for that, Tor. Hopefully I can see some questions popping up in the Q&A about that. So if you want to jump over there, you might be able to answer some. Otherwise, we'll get to them at the end. Next, I'd like to introduce Wendy Liang, who's presenting on behalf of Orthoptics Australia, to give us a practical example of the problems with reporting encountered by not using standard terminology. Thanks, Wendy.
Great, thank you. Can you see the slide there? Yep. Okay, so hi everyone. So I'm Wendy, I'm an orthoptist and I work in a pediatric ophthalmology clinic. I'm just going to be sharing a quick example of how standard clinical terminology would be helpful in our practice. So firstly, I want to explain the software and the data types we use at the Children's Eye Centre. So here on this first page, we have clinical results screen from the best practice VIP software. The software allows you to personalize what data you want to display, where you want to input and where you want to, and data is usually entered via a drop-down selection box or via free text boxes. So here we have some drop-down boxes. The options would be a selection of words that our clinic would have chosen to put in. So for example, on the left side here, we have vision results and the drop-down boxes has a list of the types of tests used. And on the right, we have combinations of drops used on a patient that we can select. Here are some examples of free text boxes that we used, and we use these mainly for history taking as well as our actual results from our tests. So you can see that although the data in the drop-down boxes can be standardized across different users in the clinic, it is actually dependent on who initially selected the terms used. And well, in the free text boxes, anything goes. This is the patient overview screen with details such as their full name, the address, date of birth, referral, etc. We also have a red box over here on the left that can be used to put in important notes, such as requires interpreter every time, needs to be seen prior to dilation, and so on. But in this box, we also have the ability to enter the patient's diagnosis for the system to store or tag using 2 /. Information stored or tagged with this symbol in front of it can be pulled as data for reports. However, as this is done via free text, there is inconsistent data entry of the diagnosis because between different clinicians, they can use different terms to mean the same thing. They can also use shorthand versions, and with shorthand, there can even be different versions, and as well as unintended spelling errors. So I've got an example here of the condition accommodative esotropia. It has been put in our system as ACOM-ET with 2 M's, ACOM-ET with 1 M, AE, AET, and this causes an issue when we have to pull data for a report. And the reason why we need reports is to do clinical audits, looking at patient outcomes, looking for any clinical associations for research purposes, and looking as to whether anything needs to change, particularly in regard to practice protocol or clinical protocol. So in this particular example, say if I wanted to see how many of my patients with accommodative esotropia developed amblyopia as well, I would have had to pull up 4 separate reports to capture all the terms. And this is just the terms that I know have been used. There would be ones that haven't been, I don't know have been used that would cover this as well. I may have to ask the other clinicians how they might have written it into the system. And I wouldn't be able to pull up any patient that had the diagnosis inputted with a spelling error by mistake. To complicate things more, this is actually the ophthalmologist shorthand as AET, because for orthoptists taught in university, the shorthand for AEET actually stands for alternating esotropia, which is a different condition to accommodative esotropia. So if the terms were matched centrally, then the terminology would stay the same between each clinician, and these reports and audits would save admin time that would be better spent on patient care. So I'm finishing up with some examples from shrimp. So for example, if the system I was using had centrally mapped terms, I could put in third nerve palsy and would put it on the left, you can see, it would pull up all the rest of these terms for the synonyms at the bottom because it's all been mapped together. It also has the acronyms. You can see on the right here, it has acronyms and synonyms. And so it would be very thorough when we pull those reports. So in summary, centrally mapped terms would be more efficient for many different tasks, as well as being reliable and thorough in its data collection and use. That's it. Back to you, Jackie.
Thank you very much, Wendy. A great practical example, and I hope that starting to help people understand why using standardised terminology is so important for getting out consistent quality data that we can then rely on for reporting and research and informing our practice within our businesses as well. Now I'll hand over to Dr. Oliver Frank on behalf of the RACGP. He's presenting tonight. Thanks for joining us, Oliver, to talk about how we can look at improving communication between allied health professionals and GPs, the current state, what can be done now to help, and how the standards will help. Thank you, Oliver.
Yeah, thank you very much, Jackie. I'm Oliver Frank. I'm a GP in Adelaide, and I'm into heavy metal, as you can see. Just get back so I can run the show here. Okay, and these are the questions that Jackie asked me to talk about. And Jackie pointed me to this report that I had not seen before from the Australian Digital Health Agency, and its conclusions are interesting. But before I go there, I was a little surprised to see that allied health professionals over on the right are apparently not healthcare providers on the left, and are mostly doctors, with practice nurses being a bit wobbly. And of course, missing in action, you can see pharmacists, orthoptists, dentists, a whole lot of other professions don't even seem to figure. So just keep that in mind. But you'll see the acronyms in this report. So it concluded that we've all become used to working with a lack of clear, detailed information from each other. And this is a new word to me, satisficing. I had to look it up. And it really seems to refer to workarounds, what we would otherwise call workarounds, trying to get people looked after without systems that really serve the purpose that we need. So this report found that we are relying on a patchwork system. We all know this. I'm not telling you anything you don't know, I'm sure. Different modes of communication. We don't have all the information we want. As has already been mentioned, we have duplication, wastage, additional administrative workload. And allied health professionals, only a third of the time are satisfied with the communication they have with GPs. And you'll see that when it says specialists, I think they're talking about medical specialists other than GPs, a few more of them are satisfied. So, it's not great. So what they call healthcare providers, which is mainly medical people, are getting some information that is helping us from allied health professionals, but you'll see in the blue a list of other things that are sometimes not provided that would help. So if I'm getting a letter back from, say, a physiotherapist about a patient I've referred, maybe I would like to know more about diagnostic results in a form I can understand, what they've told the patient to do, and these other things that are mentioned here. So that extra information might be good, but then we'll come to the question about that in a minute. I was asked to talk about what's happening now in written communication. And again, we've all seen this. Some of us still writing letters by hand. Some of us are writing by hand on paper forms. Many of us are typing letters, and some of us are entering data into online forms, like HealthLink Smart Forms, perhaps. But the really important thing, and very much on the theme of this evening, is there is no agreed structure for how we would send these letters to each other, what should be in the letters and how it's structured. Lastly, I've mentioned here how they're actually transmitted. We still get a few in the post. They are carried by couriers sometimes, and it's often the patient who's the courier. Fax is still, unfortunately, in wide use. Email is growing in use. And what are called secure messaging systems, and these are not WhatsApp. Secure messaging systems are systems like HealthLink, the most widely installed, and there are some others that are special purpose that automatically within our clinical software encrypt the letter or other message, send it to the person we want to receive it, automatically decrypt it at their end, and then it can come straight into the patient's electronic record. So these are being used increasingly, but might be superseded soon by some of the developments in FHIR that we've been talking about, which will allow systems to exchange data more easily. This was an academic paper from 2021, fairly recent, by a bunch of allied health people and Professor Tim Usherwood, who's a GP, and it says much the same as the Digital Health Agency's report. So we're saying that we really don't know the best way to communicate. Their focus was about people who'd been in hospital being discharged and the allied health professionals writing to GPs and others, but it applies pretty broadly. And saying there's no gold standard method, they said it's urgent to develop some way for us all to communicate in order to improve care. So again, none of this is news to you really. So Jackie asked me to talk about the challenges in what's happening now, and I've mentioned that. So I think not being sure what information the other party wants and needs, if I'm referring to a podiatrist or a dietitian, what does that person really need to know about the patient and me to tell them, and in what structure? So there is that lack. We're all just guessing at what the other people want to know. Importantly, those of us who are using electronic clinical information systems, electronic clinical records, do not want to receive anything on bits of paper or images of bits of paper, images of documents. We want data, which is what properly structured electronic systems would send. And I'll talk about why in a moment. And I just think it's worth pointing out that once you've spent money investing in an electronic clinical system in the computer, fiddling around with paper or images of documents, it actually costs a lot more. And if you're actually generating paper, whether it's letters you write or whether you let incoming faxes and things like that print on paper, you've got extra costs in handling it all. Jackie asked me to talk about the benefits of terminology standards. Tor has talked a bit about that already, and essentially they do allow our different clinical systems to exchange data. And one of the things about that is that the data can be atomized. So when we say atomized, I mean broken down to the small elements. In the medical world, it would be, for instance, saying in a biochemistry report that there's a label that says this is a sodium level, and then there's a number, which is the value of the sodium in the blood. When we have it atomized like that, it lets the other system use that information and match it up with other information it already has. And that's a really powerful thing. So atomization is important. It's already partly happening, but we hope to see more of it. The other benefit then of having standards is that having them lets the information be used automatically, and that's all to help improve the safety and quality and efficiency of our care. Jackie asked me to talk about the benefits of electronic clinical information systems. If you have records on paper, only one person can be using that piece of paper at a time. If you happen to misfile it, misplace it, or lose it, it's gone forever. If your whole practice burns down and burns all the paper records, they are all gone forever. So having it electronic allows copies to be kept in backup systems or offsite and lets other people access and multiple people access it at the same time. And importantly, intelligently designed systems can help because they can summarize information. They can point out where we've got data that's missing that we expect to be there, or data that's inconsistent or conflicting, which is not unusual, where people might record diagnoses that are conflicting. And it can also point to data that might be suspiciously old and should have been updated. So these are some of the ways in which these systems can help. Lastly, and I think it's been touched on, electronic systems already do help us by generating prompts to us and the patient, suggestions, reminders, warnings, and alerts. And that can help to improve the safety and the quality and efficiency of care as well. So these are all things that you probably already have some idea about. Jackie asked me to talk about what can we do now. I think it would be very helpful for each of our professions to actually tell everybody else what we need in referrals that are sent to us, and in other messages as well, and how we want it structured to make it easiest for us to understand the purpose of the referral and what the patient situation is, and how to respond to that. We can help by using systems that do conform to the standards that exist. There is still a lack of standards. We don't have standards for everything, but there are some standards that exist. So any system you use should really conform to those existing standards. And the last thing we can do then is support the development of fire resources, as in the Sparked program. I don't expect the average GP, the average podiatrist, to actually know anything about fire or what it is. I think it's a message we can just spread to say there is work being done to enable our systems to exchange data, and those projects, or this current project, is worth our organisation supporting. And for those who are interested to get involved, we do need people from all the professions involved, and they could put their hands up. And that's the end of my slides. Thanks, Jackie. And I'll stop sharing.
Thank you, Oliver.
When I can find out how. Come on.
Angela, I'll now hand over to you. I'd like to introduce to everyone Angela Vivanti, presenting on behalf of Dietitians Australia and the Princess Alexandra Hospital. Yep, got Angela's slides up, so I'll let you go for it, Angela.
Okay, thank you very much, Jackie, and I'm very pleased to share with you today our journey towards developing and using consistent terminology and our experience in trying to incorporate that into our day-to-day documentation and practice, and how it's really helped us in looking at some of our outcomes as well. So the approach we use is a nutrition care process and terminology, and it's the cornerstone for us in terms of achieving those goals. I share with you just for the purposes of disclosure, the various professional associations and committees with which I'm associated, and I hold a publicly funded position in research grants and co-authored various publications, etc. So, as a smaller profession, we knew that we would be able to better show our outcomes if we work together through using consistent terminology. And forward-thinking colleagues started the development of the nutrition care process terminology in the early 2000s. And our professional association, Dietitians Australia, confirmed endorsement of it in 2009, and then supported its dissemination with national workshops, with champions, and with Train the Trainer programs. Then, knowing that a statewide electronic health record was commencing in Queensland in 2015, we had our dietetic directors and our terminology change champions from districts right across the state meet and discuss and work together on what we wanted the system to be able to do and how our electronic documentation could be created in order to achieve those goals. And part of that was consistent terminology. So it certainly takes effort to have these conversations, but it's worth the effort because we did not want to waste the opportunity with which we're being presented. For us, we first start with creating our consistent terminology in the areas of diagnosis, interventions, and outcomes. So we start with diagnosis, or the problem that we're addressing, then the signs or symptoms, which give you the evidence of that problem, then identifying the etiology or the real cause of the problem. So, for example, if people aren't eating well due to nausea, as opposed to having limited knowledge, the interventions to resolve those problems will be very different. We then look at the intervention and select the intervention, and finally the status of those outcomes, all using consistent terminology. So using the consistent terminology meant that we could create a system that could pull information into reports, pull information into useful dashboards, and transfer information between different systems, for example, automatically communicating food allergies to food service systems. We adjusted our terminology and our documentation to support the consistent terminology. One change was an increased use of tick boxes. Another were more drop-down boxes and limited text fields, which saved you having to type. You could just select it off a list. And then we also increased the use of data cells. For example, weight would be written in a box or a cell rather than written purely as free text. And finally, limited text boxes lets you pull information and data or auto-populate the information into other parts of the chart, all of which is very helpful in terms of saving time. Now, people are always talking about outcomes, and the use of consistent terms has been pivotal with regards to easily assessing outcomes in the nutrition problems that we're resolving. Queensland's early experiences with using status terms in real practice helped our profession inform the terms that were ultimately decided for use internationally. So these terms may look simple, but they took a lot of consideration by various committees and with people from various countries before the final internationally agreed terms of new, active, resolved, and discontinued were decided. The reports that we've built into our electronic health record system all use consistent terminology. They show the nutrition diagnosis being selected by the clinicians and the etiology or the cause of the problem. They show the various interventions being utilised, again using consistent terminology. They show the status and the number of days until the nutrition problem was resolved. So here, the use of consistent terminology is assisting in clearly showing the outcomes as a consequence of our involvement in people's care. And we can pull that information that would have taken us weeks to collect as a quality improvement project. So just to explain, the system is also created so that it will assess this diagnosis regardless of setting and providing a continuum of care. So whether they're seen in outpatients, in intensive care, or onto rehab, they're using and following the same nutrition difficult problems. So we've shown improvements in several process outcomes, such as knowing that a person had a food allergy before we spoke to them, that increased fourfold, being able to locate a person's weight much faster than previously, less than a minute in most circumstances. Then we had the time, the amount of dietetic involvement. Because of the time savings, we increased the number of people that we saw by 1,000 with no additional staff. And the extra time saved also contributed to our ability to review the automatic malnutrition screening tool referrals that we received. And now we're able to identify more malnutrition. So there's been almost a 50% increase in the numbers of people with malnutrition that we diagnose and code every month ever since this has been commenced, and it's been sustained, which is, I think, is a highly important outcome considering it was achieved with no change in staff. So the use of consistent terms and data cells is what populates our comprehensive care dashboard. And it includes the ability to pull reports as well as show information in real time. So our dashboard can look at information in real time across the ward, the service, or the organisation. It includes the status of many nutrition diagnoses being managed by the organisation. For example, in this service area on the left, at the moment, you can see there are 27 new nutrition problems identified, and that means they've received one consultation so far. 27 are active and progressing to being resolved, and 16 have been fully resolved. On the right, the system also displays the nutrition classification, and so that's the number of those who are severely or moderately malnourished, 4 and 17 respectively. So viewing this easily is possible because of the consistent terminology. So just to share, due to our use of the consistent terminology as part of our day-to-day documentation, we've shown outcomes in a variety of ways. So we briefly discussed the process outcomes, such as less time to document, less time to audit, less time pulling results. We can show intermediate outcomes, such as when we're resolving diagnoses, such as inadequate oral intake or altered nutrition-related lab values. We show clinical outcomes through improving the diagnosis, such as unattended weight loss or conditions such as malnutrition. We can show patient outcomes when we're improving quality of life or comfort or satisfaction or the ability to go to work when you've resolved gastrointestinal symptoms or symptoms from food intolerance as examples. And finally, we could more easily be showing our impact on cost outcomes to health services, such as through fewer days in hospital, or preventing rehospitalisations, or needing fewer visits to healthcare service, or less medications being used. So I've mentioned certain benefits, but there have been many, and I wish to share some other real-life examples of our application of these reports and the dashboard in real practice. So firstly, with triaging workload and staff allocations. Here in this response to sick leave, I give an example of how we're able to triage 3 wards, about 90 beds in 3 minutes, and ascertain the people who really needed to be seen that day by others in the department, in addition to their regular workload. So very briefly, we sorted columns and clarified any new food allergies, any new pressure injuries, any new people at malnutrition risk, and then anyone who'd lost a large percentage of weight for whom we were not previously aware. And because the data is in cells rather than in free text, we can tabulate information and we can graph it. So using weight as an example, graphing makes it so much easier to see what's really happening with this person's weight over time. Oops. With the graphing of weights, it's easy to quickly see both the trending and the amount of weight loss, especially if someone selects unsure about weight loss without trying, which is part of our malnutrition screening tool. So it takes about 10 seconds for us to look and very quickly check if the weight loss is a concern. So in this example, we're checking people with the greatest amount of weight loss during admission. And in the first example, in just a couple of days, someone's lost a little bit of weight, but that's not real. I wouldn't be worried about that. But the next person who has in fact lost 8 kilos in a couple of months, that looks like a genuine weight loss. Again, the next person in a couple of days, there's been a bit of weight fluctuation, not worried about that. But the person who's dropped several kilos over a few months is again showing evident decline. So we'd very quickly be able to prioritise, they would be the 2 people that we would spend and prioritise to see that day. The next example involves applications for, say, doing business cases for staff and workforce. So those in management roles may have experienced having the opportunity to contribute to a proposal or a business case, but being given a very short time frame to do so. Although not normally this short, we had about an hour to compile information concerning the dietetic needs of a service as part of an additional staffing proposal that was being submitted on a particular day. So there were 96 beds in this unit, but when including people from this specialty who were in other units across the hospital, we could see that there were over 150 people currently admitted. So straight away, that's about 50% more beds that may have been originally considered, illustrating more need than may have been initially apparent. Now, previously, it would have been very difficult to pull together some facts and figures in short time to add to this business case. However, supported by the use of our consistent terminology, we could very quickly show in real evidence in real time that when you considered malnutrition, unintended weight loss, pressure injury, food allergies, dietetics were involved in the care of almost half the people in this unit, far more than would have been presumed. Thirdly, if we look at the impact of some quality improvement initiatives, that has been made much simpler because we document the nutrition problem with consistent terms, we document the status, that's the new, active, or resolved with consistent terms, and we also capture the date of a new problem and the date that's resolved, meaning that we can calculate the days to resolution. So other sections of the dashboard include more detail concerning the nutrition diagnosis and their status, and the interventions that we used. We use high-level groupings here for simplicity, but much more detailed ones are also possible. We can see if the nutrition problem or diagnosis is active or resolved, and we can see the number of days it took to resolution. Now, all of this is done as part of standard documentation and practice, so it's possible to see these results or outcomes in real time without any change. So consequently, we have assessed changes in a model of care within an inpatient rehabilitation unit, which consists of several wards. So the average length of stay in the acute hospital would be about 3 days, but there are several rehab wards in our team with much longer lengths of stay. With the design and the use of diagnosis in the status terms, we could assess the impact of changes made as part of usual documentation and with no more work or data collection required. And so we simply pulled a month snapshot of an audit before and then after a change in practice. And we could show that there was a reduction in the average number of days it took to resolve a nutrition problem from 26 down to about 22, meaning that we could resolve it 4 days faster. Now, I could pull these reports in about 15 minutes, something that otherwise would have taken a couple of months of data collection. Previously, I'd also mentioned that we had speedier access to information in the electronic charts. I did mention that we had saved about 10 minutes throughout an admission in our documentation time, and that equated to over 800 hours or about 20 weeks in a year. So that is significant, and that is time that can be redirected back into patient care, or it can be used to progress other quality improvement initiatives. And lastly, assisting with audits. In this scenario, we had a particular unit that was pulling information, including the presence of malnutrition, for use in a national health database. Now, nursing staff were very diligently searching by hand every month to provide this information. We were able to confirm that we could receive identical figures for the presence of malnutrition in this unit, whether they searched by hand, even though it was an electronic documentation system, or by pulling malnutrition reports. So as you can appreciate, hand searching hundreds of charts for malnutrition documentation is time consuming compared with pulling a report, which can be printed in just a few minutes and which provided the same outcome. And again, this gives valuable staff time back to patient care and to other important activities. And eventually, it means that reports like these could automatically feed into national databases. Again, all possible because we used standardized terms. In another example, we have undertaken malnutrition audits for many years of everybody in the hospital on a certain day. As a state, there was a desire that we move beyond just tracking malnutrition prevalence alone to auditing the parameters that support nutritional intake while they're in hospital. So there were 15 items in total that were collected during this audit. 8 of these, so over half, could be pulled from our dashboard, with the remainder being asked verbally. So even with the number of items audited increasing from 2 to 15 parameters, the number of hours of auditing substantially reduced from 120 to 35 staff hours because of our ability to pull this valuable, relevant information from our dashboard, because of our use of consistent terms as part of our standard practice, and it's showing lots of benefits in many different ways. So I reflect on what I think has been quite a long journey, on what I think are a few important lessons. For me, we really need to have the end in mind. We need everyone using the same consistent terminology so that we can move seamlessly between clinicians, between health services, and show our outcomes as a collective group of health professionals across the whole continuum of care, whether that's private or public, primary or tertiary, and not in little silos. And what we need are change leaders, not just change managers. And we need to have vision and dedication and persistence. So I thank you all very much for your interest in this topic. I'd like as well to acknowledge the traditional custodians on the lands on which we work and their resilience and continuing connection to land, water and community. And I'd like to acknowledge all of those who played a pivotal role in development and the application of standardised language for our profession. Thank you.
Thank you, Angela. So many great examples there of how these standards can help in practice. Really great variety. I'll hand over next back to Tor from Sparked. And Tor, would you like to, I guess, give us another example of how the standards can help and be used in around smart forms and where this is going, I guess, with the work you're doing, the agency and government initiatives? Thank you.
Yes, absolutely. Thank you, Jackie. Just checking that you can still hear me. Yeah, perfect. All right, so just to give a bit of context, I do want to call out that by no means am I an expert in smart forms. However, I do work with some other very intelligent people in the team who are doing work in this space. And so what I'm hoping to do tonight is to give you enough of an overview and understanding to be able to know what it means when we talk about smart forms or smart form technology, why you might care about it, and as well as a quick overview of some of the work being done in this space through Sparked and by other teams in CSIRO and at a national level. So what is a fire-enabled smart form? Essentially, it's an electronic form that uses both the fire standards we have already discussed, as well as the smart framework to enable capture of data electronically in a structured way that allows for integration into a healthcare system. So smart forms is an open standards-based form solution for health assessments in general. It's a solution that's capable of integrating into existing clinical systems. It supports the exchange of data and its reuse, and it helps to enable the capture of quality data by using a standardized approach, helping to improve efficiency and delivering clinical care. So it sounds very similar to fire, which is what I already mentioned earlier. So what does it mean when we talk about smart on fire? So SMART in this context actually stands for substitutable medical applications, reusable technologies. And the way I understand it at a very basic level, and some technical people online may correct me, but essentially the smart on fire standards leverage fire and other standards to enable additional functionality and requirements to be able to build out these electronic forms. So it's a framework that builds on fire to allow third-party applications to be integrated into existing healthcare systems to help solve those complex clinical problems. It enables the development of applications that can interact with electronic medical record systems, clinical information systems, and other healthcare systems. And the goal is to allow apps to be securely integrated and reused across different systems without having to extensively reconfigure or custom build interfaces and solutions. So it's trying to reduce that development burden to adopt new technologies and applications. So on this slide, we can see how the pieces might interact together. So for example, a smart app launch connects the application to the clinical information in a secure and interoperable patient-centric way. Use of the FHIR and AU Core FHIR implementation guide means that the information is suitable for exchange between different systems because we've already determined that it means the same thing in the background. Additionally, by using the structured data capture standards, this supports pre-population, dynamic behaviours, calculations, and it allows it to be modular and adaptive. So moving on from there, what we can see on this slide is a demonstration of how the data exchange happens. So we've got authorization and authentication happening in that arrow at the top, and then the patient information is exchanged through a FHIR interface. The middle arrow shows how the patient information is being provided to the app to support that pre-population, with the information then being able to be written back to the original patient record. So how is this currently being applied? So there are a number of different pieces of work, but from a CSIRO perspective, the team have been working on developing the First Nations People's Health Check, which you may also see referred to as the Aboriginal and Torres Strait Islander Health Check Assessment. And this particular health check was chosen as a use case as it's a very comprehensive health assessment that covers off a large number of the data elements and areas that are used across many different health disciplines and in many different environments. So therefore, it was seen to be an excellent use case to begin developing and applying these standards, as many of the same FHIR resource profiles would be reused across other smart on FHIR applications or forms developments. So Other examples of national smart app initiatives are listed on this slide, including the creation of an Australian cardiovascular risk calculator by the Heart Foundation in partnership with CSIRO. And I know that Ian Davies is also online from the agency, who'll be talking in much more detail about the comprehensive health assessment program form that they are developing. And he'll probably cover it off much more eloquently than me. So on this slide here, you can see grouped by the different functions that the form supports, how the same resource profiles are shared across the different pieces of work. So for example, you can see for the First Nations health check that the encounter, condition and observations are also used in the cardiovascular risk calculator. So it's just trying to demonstrate that as we start to build out these technologies using a standard, we can pick up and reuse the standards in the same way that we're wanting to pick up and reuse the data. So in terms of looking to the next stages of work in Sparked and to help bring the Australian core data for interoperability to life, we're also now exploring how could these data groups and elements be leveraged or used in a chronic condition management plan template. So Liam and the team in CSIRO, in their non-existent spare time, already have done some initial exploration around what could be required to create a chronic condition management template, leveraging on the work that they've already done for the First Nations People's health check, and referencing some example existing GP management plan templates that we were able to find from the different primary healthcare networks. So they were able to sort of do a bit of a cross-reference and compare to identify where some of the information that we've already defined through the work on the Aboriginal and Torres Strait Islander health check could then be leveraged to help build out a chronic condition management plan template. So through the Spark program and looking at the release of the next Australian core data for interoperability, which does include that chronic condition management component, we're now wanting to bring those discussions forward through the CDG to continue developing out what a shared a chronic condition management plan template that supports a team care arrangement or a shared care arrangement might look like. So those are some of the discussions that we'll be exploring in Sparked through the coming months and program of work. I think also to Oliver's point earlier, we want to start thinking about what do all the different professions and providers need to see in a template that supports a shared care arrangement. And so we'll be starting to explore those concepts as well. That being said, even at a high level, we can see how the actual fire resources exchange for the health check and a draft chronic condition management template are likely to be very similar. You can already identify that practitioner-patient encounter, condition, observations, medication statement, allergy intolerance, they're all things that we've already worked through in the existing pieces of work, and we can then continue to leverage off as we go forward. So I'll stop there. It's a very quick overview, but just wanting to call out, I guess, what a smart form is, how it builds on the existing standards, and then some of the work we're looking to in the future. And back to you, Jackie.
Thanks, Tor. I'll hand over now, as Tor alluded to, Ian Davies of the Australian Digital Health Agency, who can give us a specific example around that CHAP smart form and how the agency are linking that in with their systems.
Great, thanks, Jackie. Let me share my screen here. A sec. All right, can everyone see that okay?
We can, it's just not in present. Yep, now you're right. Yep.
There we go. Okay, so thank you. I'm just going to, in effect, build on what Tor just spoke about there, because what I'm talking about here is a specific smart form solution that we are in the process of building. We are actually kind of delivering on the promise of reuse that Tor alluded to there, because we are basically reusing big chunks of the Aboriginal health assessment a smart form that the CSIRO has been developing. And I guess to put a fine point on what Tor was alluding to, the appeal of smart forms is that they allow clinical information systems to basically graft really quite sophisticated functionality into their products with quite minimal work. So you build, SmartForm is in effect sort of a widget, a chunk of functionality. You build it once, you build it well, you get a very good, you invest the time to make it very kind of usable and polished, and then you make it available to clinical information system vendors to kind of graft it into their products quite easily. So the specific SmartForm we're talking about here, the specific health assessment we're talking about here is what's called the CHAP, Comprehensive Health Assessment Program. That is a health assessment questionnaire used by GPs to support individuals with intellectual disability. And it's a bit of an interesting one because there's two parts to it. There's part one is actually filled out by the carer, typically, of the person with intellectual disability themselves, and they actually then bring that, typically as like just literally a filled out piece of paper. They bring it to the general practice and hand it to the GP or the practice nurse, and they use that as input when they fill out part two of the questionnaire. And the idea of the questionnaire is to kind of identify unmet health needs of people with intellectual disability, and to come up with an action plan at the end. Now, again, this is a tool used by GPs, but I think it's quite relevant to allied health, because I know, across allied health, doing assessments of this sort, I think is very, very common, I guess. And you can probably imagine that some of the benefits we're hoping to achieve here with this kind of GP-centric tool could just as easily be achieved by allied health practitioners. But what we're actually doing is we're digitizing the part two of that form, the part that's actually used by GPs, and we're linking it into GP clinical information systems. Now, I've been politically correct here by just showing you a mock screenshot of a non-existent GP clinical information system. But of course, we're targeting all the usual suspects in GP clinical information systems: best practice, medical director, meta records. We're basically interested in getting this SmartForm enabled through as many of those products as possible. And the problem we're basically trying to solve is CHAP is a clinically proven assessment tool. It's been proven in clinical trials, but it's not used very much, partly because it's not easily accessible. GPs are busy, they don't know where to find it, it's not kind of easily accessible. So we are making it easily accessible by getting it baked into the systems that they use every day. And we're also doing our level best to actually make it, because it is quite a long form, to make it as easy as possible for GPs to actually fill it out and get value of it out of it, to just minimize the barriers to usage. And I'll just whip through, and I'll do this very quickly. I'll just whip through a few screenshots of just what it looks like, so it just is a bit more tangible for people. We're about 80% finished building this thing, so it's not quite there, but this will give you a sense. You start off, you click a link in best practice or medical director or whatever, and it blows up a little window, and it shows here the available forms that you could use. And again, we are there are other smart forms out there like the Aboriginal Health Assessment and others that we want to kind of have presented in a similar way. You click through and then you start filling out, down the left-hand side here, you've got a whole series of sections of this assessment. The first one is background. You start filling out, background details of the patient. And then you just step through the questionnaire, basic examinations, and you start, answering various questions and start filling it in as you go. And then as you answer questions as part of the assessment, behind the scenes, it starts actually building up the action plan that you review at the end. And then it's got supporting tools like the etiology guide, which talks about what conditions are highly correlated with which symptoms. So we have that useful information right there at the fingertips of the GP, so they can kind of quickly reference it. And then you can have you can save forms in draft. You can refer to old forms, etc. That's it for the screenshots. One key point to mention here is, as part of building this CHAP solution, we are actually building behind the scenes a national infrastructure that will support the operation of other smart forms. So we are, Tor alluded to there are three kind of smart solutions that are in development as we speak: the Aboriginal Health Assessment, the CHAP, and then the third one, the Cardiovascular Disease Risk Calculator. Those three are the kind of the pioneers, and we're all working together to kind of deliver those solutions. One of the contributions that we're making is to stand up some national infrastructure, a place to host these forums and these smart apps, whatever, to basically lower the cost of the people that come behind us that want to build more kind of smart forms of this sort, to make it easier for them and cheaper for them to actually build those sorts of solutions. So that's one of the things that we're kind of in the process of doing. And one of those components is a terminology server, which is the Cyro's Onto server, which goes to the topic of today's webinar, which is all about the clinical terminology side of things. And this is actually just a very simple and straightforward example of how clinical terminology will make the experience better for clinicians. And, very simply, it's all about pre-population of data and then writing back data. So when GPs fill out this assessment form, as much as possible, they don't want to be, filling out the basic details, name and so forth. They would like for that to be pre-populated for them. Similarly, when they kind of come up with new observations through this assessment, they want to be able to have that information written back into the local patient record, so there aren't like two different versions of the truth, and it just kind of saves them that time. So that's what this Smart on Fire functionality that Tor explained a bit earlier, that's part of the big value proposition. And similar to what Tor was pointing out, there are just certain fields here that we are working through what we will be able to pre-populate, such as name and date of birth. We're hoping to be able to pre-populate condition and immunization details. We're still working through that. And to pre-populate fields like blood pressure, body height, body weight, heart rate, waist circumference. And then we're also, and again, we're very much in the kind of solutioning phase of this, looking at the ability to write data back to the underlying patient record. And again, as you might expect, things like blood pressure, body height, body weight, heart rate, and waist circumference. That's all, there's a lot of intricate work behind the scenes to kind of make sure that that's all doable. But that's, I guess, the promise of this technology. And we are, I guess, quite well advanced in it now. And it's all looking quite promising. So we are a few months away from having this solution built. We're aiming for about September, and then after that, it'll be about working with the GP clinical information system vendors to get it out there and get it into their products. And that's a separate sort of exercise and timeline we have to go through. But that's what we're working towards. And it's the type of thing that we're in early conversations with a lot of other stakeholders on about, where else in the health system and in other sectors could this sort of technology be useful. And allied health would be one of the obvious candidates in there. So I think it's got a lot of promise, and it's quite exciting. And that was effectively what I had to say on that. I will stop sharing my screen.
Thank you, Ian. We certainly look forward to working with you on other, allied health, more specific examples of how that technology can be used. That'd be great.
Sure.
Now, we're fast running out of time, everyone. Sorry, I'm conscious of the time. So we have tried to answer all your questions in the Q&A. So for those who popped them in the chat, if you jump over to the Q&A tab next to the chat, you'll see I've populated some answers in there to some of the questions that were in the chat, if you haven't seen that already come through. Otherwise, please do get in touch with me at AHPA, and we can follow up anything else that you've got burning questions about. But just to finish off, I'll hand back to Tor as to how you can get involved in this Spark work and what sort of skills you may or may not need, probably different to what you think, to get involved and really help move this forward for our sector. Thanks, Tor.
Thanks, Jackie. So ultimately, there's no barrier for entry to get involved in Spark. If you are a healthcare provider or a clinician currently practicing, then your input is valuable in this space. So we're really keen to spread the net as wide as possible to get participation from all different areas and backgrounds of those delivering healthcare and healthcare services in Australia, because we want to make sure that in alignment with our bottoms-up approach to building out these these standards that we are incorporating as many different perspectives as we can. So we want to make sure that we build out these standards for the Australian healthcare community as much as possible, and the best way for us to do that is to encourage participation from everyone who has the interest and the passion to talk about standards. So the easiest way to get involved is really to join one of our clinical design group if you're from a clinical background, or our technical design groups if you're from a more technical background. I will say though, the reverse is true. So if you are a clinician who is really interested in understanding or learning a bit more about the technical side of things, these groups are very open, they are very collaborative, and there is a very learning focus. So there's no silly questions. If you are someone who is interested in learning more about the technical side of things, please don't feel like you can't join one of our technical design groups. They are open. And similarly, if you are of a more technical bent or technical expertise and you would like to have a better understanding of the discussions in the clinical side of the development of the standards, please feel welcome to join the clinical design group as well. There are up on screen some other activities that we do. So we do try to run webinars regularly. There are connectathons, which are where we sort of test and pilot the standards actively with vendors in the community. And then we also are constantly seeking feedback from the community. So we publish all of our materials onto the Sparked website, and it is open and transparent. You can access them if you're interested and have some light bedtime reading, and also we are very welcome to anyone reaching out to us as well. So I'll just quickly go to the next slide, where the QR code will take you through directly if you're interested in registering to participate in Sparked. But also please feel free to jump on our website and explore and have a little look around as well. We do have a Sparked podcast if you're interested, if you prefer to listen to information. We've done season 1 and we're actually in the process of recording season 2 as we speak. And we share a lot of information on LinkedIn as well. So I think that sort of is what I had to just call out there. And then, I'll hand back to you, Jackie.
Thanks, Tor. I've just popped a direct link to the clinical design group in the chat as well, which might interest a lot of our audience here. And just, yes, our CEO, Bronwyn Morris Donovan, will be featuring in the second series of the Spark podcast. So watch out for that, everyone. I can see that I know we're 5 minutes over time, so please feel free to jump off if you need to, anybody, but there is only one question we haven't answered so far during, and I just wonder if any of our panelists would be prepared to comment on the question that's at the top there now. It says, from Andy's asking, reusing data can be very helpful for the many reasons our speakers have highlighted today, but I'm curious about some of the risks of reusing data. For example, unknowingly propagating any error through multiple systems. What safeguards exist to prevent this and ensure data quality is maintained? Is anybody able to comment on that?
I can't see the question. I've got one from the chat about atomization. Is it above that?
Yeah, Ian, would you like to comment on that one?
Yeah, I guess if it's helpful, it's certainly a question that we've been wrestling with in the CHAP project and in the design of our smart form, and because there is this tension, right? There's a desire to pre-populate data and reuse existing data and stuff like that, but at the same time, you don't want to fall in the trap of perhaps pre-populating with old data or removing the prompt, I guess, to get the person that's, whether it's the GP or the practice nurse, to actually use that opportunity with the patient in front of them to get updated data. So there's no hard and fast rule other than that we have been user testing this along the way extensively with clinicians to kind of say what's going to be appropriate here and to err on the side of caution in terms of what we pre-populate. and again, it's things like name and date of birth and stuff where, it's a kind of a safe bet. So we are erring on the side of only pre-populating the stuff that we're really comfortable pre-populating, but it's a great question because it's something that people have to wrestle with in the design of these sorts of things, and we can't let kind of expediency or just because the technology allows it to trump the fact that clinical safety comes first, and data quality is critical to that. So it's a balance that I think we all have to strike.
Yeah, thanks, Ian. And I just add to that, I guess that's why it's so important that the data we're entering is quality data, and is usable through the system, so that we're only reusing quality data. But the other thing I guess I've learnt from being involved with Sparked is that there will always be sort of a clear pathway as to where this information came from will be sort of shown as well. So you'll be able to trace that back to its source, and we might be able to solve something if we're unsure of the data. Kylin?
Yeah, I was going to mention the provenance part of it. I think that's really come out really loud and clear in our clinical design groups, that it's really important for us to know where the data came from. So no matter how it transfers from system to system, to know where it came from originally has been really important. And is part of the Aboriginal and Torres Strait Islander health check work. It has been an important discussion, like currency of data. And I think, Ian, you're kind of mentioning that it's like how old should you be using certain blood pressure take readings or anything like that, and those are really important to know, like when the readings were taken, so that if you are reusing it, is it actually appropriate to be reused, and what are those dates? And I think it is very much a use case basis, and so when you are designing these things, it's really important to kind of have those discussions with your clinical experts.
Thank you. Oliver?
Yeah, it is an important question. I mentioned in my slides that we hope our systems can help us by pointing out inconsistent or conflicting data. So that's one function. And I was going to say the same as Kylin about provenance. When I look at data, I want to know who recorded it, on what date, and preferably I like to know on what basis they recorded it. What is the evidence, whatever they put there. That's asking more, but it's not completely out of the question, because if I know somebody recorded it and they're very junior, or I think they're not very smart, or tend to get things wrong a lot, I'm going to take a different view than if it's one of my most highly respected colleagues, in whom I have great faith. So it just helps to know all about that as much as possible when we're trying to judge how the quality of the data is likely quality.
Yes, and I think the key thing to learn about all of this is it's still sharing information from others, and it's still never going to replace your clinical judgment and checking things with the consumer that you are doubtful of, those sorts of things. You still need to do your clinical due diligence and be responsible in the way that you are now. It's really about making sure that reporting of images and results and other key bits of information that you can rely on there and available, and you'll be able to contact that person if you have any concerns about the information in there, because you'll have their contact details, for example. So it will still, even if you have some doubts about the information that you're looking at, or there's conflict between what the consumer's telling you and the system's telling you, there's more immediate ways to solve that than what there is now still. All right, I think given the time, and I can't see any other questions, we might draw that to a close. So I'll say thank you very much again to all our presenters. Really valuable, the information that you've shared, and we really value the time you've spent sharing that with us all. Thank you very much. As I said at the start, we have recorded this, and we will be just sort of, I guess, streamlining the webinar and popping it up on our website and our Digital Health Hub in the next couple of weeks when it's ready to go. Please reach out to me directly if you have anything else. I can see lots of clapping hands popping up, so thank you. I hope you all enjoyed it. It was wonderful to see so many of our allied health community joining the webinar tonight, and we hope to have a lot more digital health related education information coming your way direct from AHPA. So please continue to watch our socials for that, and our website, and join us And please get involved in Sparked and contribute. We need everybody with their niche clinical specialties to make sure that the words you need to record and share are included in the national standards, so that we can make sure this information is moving around our system in the way we need it to. And it's not just GPs info going around. We all know that we need the allied health information to give that whole consumer story. So thank you very much.